Hello, I'm Dr. Trevor Janz. I've been working in the emergency department in Nelson over this last 25 years, and I do long-term care. I care for the frailest of the frail elderly in the last year or two of their life. I want to talk today about advanced care planning. Advanced care planning is a conversation about what you would value and the choices that you would make as you approach the end of your life. And it's important to think about that in advance so that you've got some sense of what you would or would not want for yourself. Dying used to be simple. In the bad old days before antibiotics, death was expected. It was straightforward. There were no choices. Penicillin came in the early 1930s. Many of the conditions that would have killed us years ago are now treatable and we can survive them. The timing of our death is now more negotiable, but the choices are a lot more complicated. Many of these treatments might extend the length of our life, but unfortunately they sometimes don't improve the quality of our life, and we're much weaker and frailer and often hospitalized and unable to get out of bed, and our quality of life may not be what we had wanted before. We are living longer, and some of us are lucky. We go right to the last bit and then die cleanly. In my world, and for all of the patients that I take care of, that's not the case. We get weaker and weaker. We're less and less able to do what we did before. We need more and more help. We're less and less happy with the quality of our life. Oftentimes, as we're getting more frail, something big will come along. A fall, a hip fracture, sometimes a heart attack or a stroke. Modern medicine can now swoop in and rescue us, can keep us alive through that. But oftentimes we're even more weak or more frail or more debilitated than we were before. When something big comes along, we often have to make choices in a hurry, what it is that we would want for ourselves. Taking the time to think now about what choices we would want, what choices we would make, what things we value, gives us the opportunity to think about it more carefully and to decide and talk to our families about what we would or would not want. For instance, if you've had high blood pressure, or you've been a smoker, or you've got a family history of heart disease, or you've had angina, tightness or heaviness in your chest, all of these increase your risk of possibly having a heart attack at some point in the future. If you were to collapse in the middle of the road, would you want an ambulance called? Would you want them to come and try and do chest compressions, CPR, to keep your blood circulating? Would you want them to do defibrillation, to run an electric shock through your heart in an attempt to get it going? Would you want them to intubate, to put a tube down your throat, to try and breathe for you, to keep you going, connect you to a ventilator, a life support machine, knowing that for all of the time that your brain is without oxygen, irreparable brain damage can result? Many people, when they hear about CPR, say, well, of course, why wouldn't you try that? Why not? Give it a go. If it doesn't work, it doesn't work. Here, unfortunately, we're victims to the Hollywood myth. Because in Hollywood, 80–90% of people who get CPR and defibrillation are up by the end of the 30-minute television show, looking lovingly into their lover's eyes. They leave the emergency department hand in hand. The reality is that if you're over 65 and you have a cardiac arrest in the community, away from the hospital, out of 100 people who have an arrest that we defibrillate, we'll only be able to get your heart started 25 or 30% of the time. And of those 25 or 30 people, only 10 of them will still be alive in the hospital a month later. And of those 10 people, only 2 or 3 will ever leave the hospital, walking or in a wheelchair, and often with some degree of brain damage from lack of oxygen in the time that they were down. Another important crisis point where you might be obliged to make some important decisions would be if you had a major stroke. If you had a stroke that took away not only your ability to speak and to understand, but your ability to swallow. Some people would want us to put a feeding tube in through your nose down into your stomach to keep you alive, to feed you. Other people would say, if I can't walk and I can't talk and I can't get out of my wheelchair and I can't even swallow, I don't think I want that to go on any longer than it has to. Please, no thank you. I would not want anything that would keep me alive at that point. I would not want a feeding tube. It's an important thing to think about, especially if you've had any of the risk factors for stroke or some early warning signs of stroke already. These are important things to talk about with your family. These healthcare decisions are important, and trying to make them when you're panicked, when your family's panicked, when you haven't had a time to think about them, is exactly the wrong time to make these major decisions. It's really important that you and your loved ones speak about them. Advanced care planning is a conversation with your loved ones, with your partner, with your family, with your children, with your doctor, about what it is that you value, the choices that you would make if you were faced with these major changes in your health. Of course, we can't anticipate every situation. All too often, you won't be able to speak for yourself. And another piece of advanced care planning is making sure that other people around you understand what your wishes are, so that if they were asked to speak for you, they would understand what you really want. If you think that there might be difficulties in your family and not all of your children or loved ones could agree with each other, you can appoint a substitute decision maker. The important part, the substitute decision maker has to be able to not speak about what they want, but to say, this is what my loved one has expressed to me, what I know he or she would want. Advanced care planning is an exploration about our values. As I get older, as I get frailer, would I want medical intervention to keep me alive if I couldn't do the things that I enjoy doing now? If I was no longer able to get out of bed by myself? If I wasn't able to walk? If I wasn't able to recognize and communicate with my loved ones? If I wasn't able to think clearly for myself, would I want to be kept alive under those conditions? How do I feel about being kept alive on machines if I'm in a coma and there's little chance for my recovery? These are all things that we need to think about and talk about with our loved ones, because if we're in that situation, we may not be able to speak for ourselves, and our loved ones, our partner, our family, our children, our doctor, need to understand what we value, what we would choose in that situation. Physicians have a new tool, medical orders for scope of treatment, MOST, a document, a doctor's order that a doctor completes that encapsulates, that summarizes the conversation that he or she has had with you about your preferences and your goals. There's room on the form for the doctor to indicate such things as blood transfusions, or life support, or renal dialysis, or admission to the intensive care unit, or surgery. All these can be specified on the form by the physician. And the important piece is that this document will be available to all physicians across Interior Health. You can redo this at any time and make sure that it's in the computer database as often as we need to. The medical orders for scope of treatment is not a restaurant menu where you say, well, I want this, 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 and this. I, as your treating doctor, the emerge doc, your specialist, your family doctor, will always offer you treatments that they believe will be helpful for you. And it's important for you to think about it and tell us which ones of these you would want to accept. I emphasize that if we need to make an important decision with you, I will always ask you, and if you're able to answer me, what you tell me right then and there is what's most important. We only use the MOST document if you're no longer able to speak for yourself. If we don't have a MOST document, we're left trying to find a substitute decision maker who can hopefully speak to us about your wishes. So it's important to have these conversations with your family as well, so that they all understand what you would want. When should I start thinking about advanced care planning? Well, the answer is, of course, right now. It's never too soon to think about this. If you've got a chronic condition, heart disease, liver disease, kidney disease, if you've had a heart attack or a stroke already, or if there's a strong family history of these, if you've been a smoker, if you've got high blood pressure, if your cholesterol is high, if you've got angina, or any of those things mean that it's time to start talking about this with your family and with your doctor. If you have a serious condition, it's really important that you book some time with your doctor to talk about how your condition is going, what decisions you might face in the future. It might be difficult to talk about, but please ask what the end might look like and what decisions you might have to make at that point. Talk about what your quality of life might look like. If you've got a major procedure or something coming up, it's okay to ask, and I want you to ask. If this goes well, what's the best that I can hope for in terms of quality of life? If this goes badly, what might that look like for me? These are things that you need to know so that you can decide if this is something that you want to proceed with. It's really important that you understand that you have the right to say no thank you at any stage in this process. What we'd like most to do is to respect you and your choices, what you value, what you want. Many people are caught up in hospitalization and a whole bunch of interventions with very poor quality of life, and it just keeps going and going, and no one tells them that they actually have a choice about this. When we do a really good job of advanced care planning conversations with patients and families, families are empowered. Patients feel a greater sense of confidence and hope and trust. They have a greater sense of control over their life and a sense that their voice will be able to be heard right to the end. At every stage in this process, we want your preferences to help guide us about what we're doing and to do the right things for the right reasons at the right time for you.